Hello everyone, I'm Hania and my partner is Christina. We have some information about cerebral palsy that we would like to share with you. Irreversible and non-progressive condition, cerebral palsy is a group of disorders related to the cerebral cortex and impacting movement and posture. The cerebral cortex is a part of the brain that directs motor function, and cerebral palsy is the most common impairment of motor function in childhood. The symptoms of cerebral palsy might not be obvious right after birth. Symptoms are usually observed during the first year, but if they are mild, cerebral palsy can go unnoticed for several years. Common symptoms are delays in development milestone, like not sitting independently by 8 months, hypotonia or hypertonia, which are variations in muscle tone, like being too stiff or too flaccid, weak arms and legs, exaggerated reflexes, ataxia, a lack of balance and muscle coordination, involuntary movements like dystonia of eyes, difficulty walking, like walking tiptoes or asymmetric gait, difficulty swallowing, drooling, tremors, and seizures. While it is known that cerebral palsy is a result of damage to the developing brain, the cause is often unknown but believed to be related to abnormal development of the brain, bleeding in the brain, or severe lack of oxygen. Based on when the damage to the brain occurs, there are two types of cerebral palsy. In congenital cerebral palsy, the damage occurs during fetal development, and in acquired cerebral palsy, it occurs during or after birth. In our research, we found some disagreement about which type damages occurring during birth belongs to. A history of stillbirths, miscarriages, low socioeconomic status, and assisted reproduction increased the chances of conceiving a child with cerebral palsy. Other risk factors are maternal thyroid disease, infection, seizures, and toxic substance abuse or exposure during pregnancy. Prematurity, which is a significant risk factor. Intrapartum hypoxic ischemic encephalopathy, or HIE, which could be due to complicated labor and delivery, breech position of the baby during birth, or even multiple births. Perinatal jaundice and kernicterus, which occur due to blood type incompatibility of mother and child. Most common is when an Rh negative mother's antibodies see Rh positive red blood cells of the child as foreign antigens and they attack them. The breakdown of the red blood cells produces bilirubin, and when the baby's liver cannot handle the buildup, jaundice develops. When the buildup is too high, it moves into the brain to cause brain damage, which is called kernicterus. Green pigmentation of deciduous teeth may occur due to kernicterus. After birth stroke, seizures, infection, and severe head injury are also risk factors for cerebral palsy. The diagnosis of cerebral palsy is based on a combination of clinical signs that emerge before the age of 2 and standardized neurological and motor assessments. Motor dysfunction, the essential criterion for diagnosing cerebral palsy, is measured by the quality of movement in all limbs. The diagnosis requires at least one additional criterion. An abnormal MRI showing evidence of white matter injury, cortical and deep gray matter injury, and brain maldevelopment, or a clinical history that indicates risk factors for cerebral palsy or evidence of prenatal developmental defects. The specific needs of patients with cerebral palsy differ widely since patients are unique and have varying degrees of impairment. Classification is important to understanding the impairment of a patient, coordinate care, customize treatment, and manage expectations. Cerebral palsy is classified by severity as mild, moderate, and severe. It is classified by the limbs affected as quadriplegia, where all arms and legs are affected, diplegia, where both arms or legs are affected, and hemiplegia, where an arm and a leg on the same side are affected. Monoplegia, affecting one limb, and triplegia, affecting 3 limbs, are rare types. Cerebral palsy is also classified by the parts of the brain that is damaged. Spastic palsy is the most common type and involves damage to the motor cortex. Patients have an increased tone and tension in their muscles, which can impact one or all their limbs. Even the oral structure can be impacted. Spastic palsy is characterized by spasms, stiff and jerky movements, and frequent falls due to complete or partial loss of control of the muscles. Dyskinetic or apoptoid palsy involves damage to the basal ganglia. Patients experience fluctuations in the muscle tone and have trouble directing the motion of their muscles, which appears as exaggerated movements. The condition is characterized by constant, slow, and involuntary writhing and twisting movements. The intensity of movement is influenced by the patient's emotional state, like being stressed, and external stimuli like sudden sounds, bright lights, and people moving, all of which occurred during a dental appointment. Patients might appear restless and can only be still if they are completely relaxed. When the muscles in the face, lips, and tongue are affected, they cause grimacing, drooling, speech difficulties, and trouble swallowing. Ataxia palsy involves damage to the cerebellum, which is the balance center of the brain, resulting in clumsiness and instability. Patients lose depth perception, are shaky, have trouble coordinating their movements, and walk with uncertainty. Gentle, firm pressure on a shaky muscle can help calm their tremor. A combined or mixed palsy is when more than one part of the brain is damaged. About 75% of patients with cerebral palsy also suffer from chronic pain, some having primitive reflexes or abnormal responses to stimuli. Asymmetric tonic neck reflex is a condition where turning the head to one side would cause the arm and leg on that side to extend and stiffen, while the other arm and leg flex and bend. Tonic labyrinthine reflex is a condition where bending the head backward would cause arching of the back and extending of the limbs. In some, exaggerated and uncontrolled movements get triggered due to startling stimuli. Some patients have muscles stuck in an abnormal position, spastic muscles or joint deformation, and will need body stabilization and support. More than half of patients with cerebral palsy have seizures, and most have intellectual disabilities. Visual and hearing impairments are common too. Losing control of the muscles involved in speech, they might speak slowly or might be hard to understand. They might also have difficulty processing auditory information. Only about 49% have intellectual or cognitive disabilities. Hence, difficulty communicating should not be assumed as a lack of comprehension. While cerebral palsy is not curable, early detection and early interventions such as constraint-induced movement therapy or CIMT and goals activity motor enrichment or GAME can maximize neuroplasticity and improve outcomes. A team of multidisciplinary healthcare providers is often involved with caring for a patient with cerebral palsy, including oral healthcare providers. Patients might use orthotic devices to support the lower body or use a cane, walker, or wheelchair to increase their function. For some, surgery may be needed to address orthopedic deformities, correct eye or ear difficulties, or to severing nerves to relax muscles or reduce chronic pain. Medication for cerebral palsy is mainly to manage symptoms and prevent complications. The common drugs prescribed to a patient with cerebral palsy are muscle relaxants to reduce tremors and control spasticity, benzodiazepines for controlling spasticity and managing seizures, anticholinergic agents to reduce involuntary movements. They have also been found to be useful in the management of sialorrhea or excessive salivation. Dopaminergic anti-Parkinsonism agents and anti-epileptic agents can help reduce involuntary movements. Anticonvulsant agents are prescribed for seizures. Anti-inflammatories like aspirin, NSAID, or steroids help with the pain. Antidepressants help with depression and anxiety. Constipation is a common problem, and a prescription for stool softeners is not uncommon. While the incidence of dental caries might be higher in patients with cerebral palsy, their risk factors are the same as the general problem. For them, spasticity of orofacial muscles can interfere with daily oral care, and limited motor functions can make oral hygiene self-care difficult. With inadequate biofilm control and limited access to oral health care, these patients are at a higher risk of developing caries and periodontal diseases. Patients should be encouraged to gain independence in their daily oral hygiene. A dental hygienist should ask the patient to show how they brush and floss, and then make recommendations on brushing and flossing methods as well as tool adaptation. Using a rubber band or strap to hold the toothbrush would help patients with their independence. Patients with impaired motor or cognitive skills cannot participate in self-care and would be dependent on a caregiver for their oral hygiene. The caregivers should be educated on proper brushing and flossing techniques. Either way, electric toothbrushes, mouth props, oral irrigators, and floss holders can simplify daily oral care. Some of the medications prescribed to patients with cerebral palsy reduce salivary flow or contain sugars, which would accelerate the formation of dental caries. Patients should be advised to drink water frequently and rinse their mouth after oral medication. Caregivers could use a wet gauze to clean the surfaces of the teeth. Fluoride and sealants are suitable preventive measures a dental hygienist should consider. Phenytoin, an anticonvulsant used to manage seizures, is known to cause gingival enlargement. If suspected, the physician should be consulted to reduce the dose or substitute. The incidence of malocclusion is high among patients with cerebral palsy. This is more often due to musculoskeletal deformation rather than misaligned teeth. Mouth breathing, tongue thrusting, and difficulty swallowing can contribute to open bite and protruding anterior teeth. These and malnutrition due to feeding difficulties can contribute to the development of periodontal diseases. This malocclusion can lead to gastroesophageal reflux, which would increase the risk of erosion and caries. Constant and involuntary bruxism is also common, and mouth guards can help if gagging is not a concern. Patients with cerebral palsy are prone to seizures and frequent falls, which would increase the risk of injury or fracture to the teeth and the jaw. Caregivers should be educated to seek professional care immediately when trauma to the mouth occurs, since tooth fragments can enter the airway and cause complications. Also, patients with developmental disabilities are prone to abuse, which often presents as oral trauma. A dental hygienist who suspects child abuse by law has to inform Child Protective Services. Hyperactive bite and gag reflexes can be a problem during dental appointments and home oral care. Placing the chin down, inserting instruments gently, and using a mouth prop can help. For patients that have a gag reflex, an early morning appointment before eating and drinking can help. Dysphagia often accompanies cerebral palsy. Food stays in the mouth longer and increase the risk of dental caries. Softer foods that might be offered to these patients will stick to the teeth and contribute to caries production. Caregivers should be taught to clear all food debris from the mouth after every feeding. Due to numerous associated oral characteristics and predisposing factors, the incidence of periodontal and gingival infections among patients with cerebral palsy is high. Many also have heavy calculus buildup. More frequent oral hygiene checkups can help identify problems and apply preventive measures. It is best to have short appointments for patient comfort, but if long appointments are required, offer frequent breaks. Pre-medication with a muscle relaxant can help. Prescription strength fluoride toothpaste would help remineralize enamel and prevent tooth decay. Due to the high incidence of dental caries, a prescription for chlorhexidine should be considered. Since patients are prone to involuntary movements, fasten a piece of floss to radiographic films, use mouth props, and get an assistant to help. In some cases, nitrous oxide or general anesthesia might be the only option.
Parkinson's disease. Parkinson's disease is an incurable, progressive, neurodegenerative disorder that affects movement and often includes tremors. While its cause is unknown, the condition is linked to the breakdown of dopaminergic neurons in the substantia nigra of the basal ganglia, where posture, support, and voluntary motor motion are controlled. With their loss, dopamine levels decrease and cause abnormal brain activity and movement impairment. The cardinal symptoms of Parkinson's disease are tremors in hands, arms, legs, jaw, and face, rigidity of the limbs and trunk, bradykinesia, slowness of movement, and postural instability. Parkinsonism is an umbrella term for disorders that manifest with some or all of these conditions, and the most common cause of it is Parkinson's disease. The condition was first described in 1817 by a British surgeon named James Parkinson, who called it the shaky palsy. Parkinson's disease is also known as paralysis agitans and Parkinson's syndrome. There are more than 10 million people worldwide living with Parkinson's disease, and unfortunately, the U.S. has the largest share among all countries with nearly 1 million. In the U.S., about 60,000 are diagnosed with Parkinson's disease every year, and it is expected that the prevalence here will rise to 1.2 million by 2030. The incidence of Parkinson's disease increases by age, but only about 4% are diagnosed before the age of 50. Also, men are about 50% more likely to have Parkinson's disease than women. Parkinson's disease is believed to be the product of a complex interaction between genetic, environmental factors, and lifestyle. Several genes, such as GBA, have been identified in which mutations can affect the risk of developing Parkinson's disease, but they are not necessarily hereditary. That said, having a parent or sibling with Parkinson's disease increases the likelihood of developing it. Long-term exposure to pesticides, herbicides, metals, and some chemicals is believed to increase the risk too. Traumatic brain injuries and concussions are found to have a causal relationship with Parkinson's disease, But you might be surprised to learn that nicotine from smoking and caffeine reduce the risk of developing Parkinson's disease. This does not mean that you should pick up smoking to keep Parkinson's away, because the harm from smoking far outweighs the benefit. Having high levels of vitamin D, urate, or cholesterol in the blood is believed to lower the risk of Parkinson's disease, and so is regular exercising early in life. Those extensively taking ibuprofen or water-soluble statins are found to be less likely to develop Parkinson's disease. However, there has been a decades-long debate over statins with conflicting findings, but having high levels of cholesterol is universally believed to be productive. Fat-soluble statins cross from the blood into the brain. A physical exam, blood test, and MRI would help the neurologist with differential diagnosis to rule out multiple system atrophy, brain tumor, drug or toxin-induced Parkinsonism, and others. Then, a DAT scan might be used to confirm the diagnosis of Parkinson's disease. Apart from the cardinal symptoms, patients with Parkinson's disease might also present with a forward-bending posture, slow motion response, shuffling gait and small steps, difficulty with balance and turning, monotonous and slow speech, resting tremor that reduces or stops when performing purposeful activities like brushing, a motion like rolling a pill between the thumb and index fingers in circles, orthostatic hypotension, which is low blood pressure when standing from a sitting position, cardiac dysrhythmia, hyperhidrosis or excessive sweating, bladder and bowel dysfunction, sleep disorders, depression, handwriting that gets smaller and smaller, smell dysfunction, and only in advanced stages may be cognitive degradation. They have a fixed mask-like expression with reduced blinking. They might have exaggerated movements of the lips like lip pursing, the tongue like tongue thrusting and fly catching, and neck. In the later stages, when the muscles involved with swallowing weaken, impaired swallowing occurs, which would cause choking and drooling. Also, some patients experience burning mouth syndrome. Parkinson's disease progresses through stages. In the early stage, they would have mild tremors or stiffness, but can perform normal daily activities. This is often when they are diagnosed. In the moderate stage, they would have mild to moderate tremors and slow movement. In the advanced stage, they would experience significant problems with posture, movement, and speech. The progress of the disorder can also be expressed in 5 numbered stages, starting from stage 1 with symptoms on one side of the body, through stage 5 when they are wheelchair or bedbound. Treatment options are mainly to manage the symptoms using medication and improving motor functions via physical therapy. Over time, some patients develop resistance to the medication, and a surgical procedure named deep brain stimulation is employed to implant neurostimulators to treat motor symptoms. These devices are sometimes called brain pacemakers. A less common and irreversible procedure can be performed where lesions are made in the brain to suppress overactive regions. Some anecdotal evidence suggests symptom relief using marijuana, but it has not been studied enough. The most effective medication for Parkinson's disease is a dopamine promoter named levodopa, prescribed to replenish the shortage in the brain. Alone, it causes nausea and vomiting. To prevent the premature conversion of levodopa to dopamine in the bloodstream and allow for lowering the dosage to reduce side effects, it is combined with the decarboxylase inhibitor, which cannot cross the blood-brain barrier, often carbidopa. Levodopa-carbidopa combination is the most common medication prescribed for Parkinson's disease, but long-term use can cause involuntary movements and resistance. Dopamine agonists mimic the effects of levodopa but are less effective. However, they are used as the first medication to delay the initiation of levodopa. Patients who experience wearing off with levodopa are prescribed COMT inhibitors to allow more levodopa to cross into the brain. Monoamine oxidase B, MAOB, breaks down dopamine, and MAOB inhibitors help slow the breakdown of levodopa to extend its effectiveness. Anticholinergic agents are used to reduce stiffness, tremors, and poor muscle control. Adenosine antagonists are also known to help extend the effects of levodopa. Cholinesterase inhibitors, antipsychotics, and CNS stimulants help with the secondary symptoms. With motor impairment, tremor, and rigidity, patients with Parkinson's disease will have worsening dexterity. Using a rubber band or strap to hold a toothbrush would help patients with their independence. Electronic toothbrushes, oral irrigators, and floss holders will make oral care easier. Patients should be instructed to use their stronger arm and prop their elbows to maintain motor control and minimize fatigue. Patients having trouble cleaning their dentures can stick a suction cup to a nail brush and mount it on their sink to rub their dentures to it for cleaning. Xerostomia is a common side effect of their medication. Patients should be instructed to drink water frequently, and substitute saliva should often be considered. Their tremors can lead to attrition due to bruxism, and mouth guards can help. Since they might have trouble swallowing, food stays in their mouth longer and increases the risk of dental caries. Patients should be instructed to clear all debris after eating. Excessive salivation is also common, which can increase the risk of infection. It's best to have short appointments for patient comfort. If long appointments are required, offer frequent breaks and ask if they need the bathroom. Accommodate their on times for appointments. Prescription strength fluoride toothpaste would help remineralize enamel and prevent tooth decay. To prevent infections from sialorrhea, a prescription for chlorhexidine should be considered. Since Parkinson's disease progressively worsens, at every appointment, reassess the patient's dexterity. If they have a caregiver, educate them on proper daily oral care. Since patients are prone to involuntary movements, fasten a piece of floss to radiographic films, use mouth props, and get an assistant to help. In some cases, nitrous oxide or general anesthesia might be the only options. Since patients with Parkinson's disease often suffer from orthostatic hypotension, be cautious while adjusting the dental chair and allow them to sit up before standing up.